Hi guys, welcome back to my channel, and today's video is another important case of ours. The topic for today is rheumatoid arthritis. So let us start, and in this video I will be including the history, the examination in quite detail, and then we will also discuss the provisional diagnosis and the differential diagnosis, as they all are very important points. And in each section I will be thoroughly explaining any important points that are normally missed by you all. Do not forget to subscribe the channel and hit the bell icon, and with the subscription, obviously any new case, because there will be many cases ahead, not only of medicine but of other subjects too, like surgery, obs, gynae, pedia, and therefore the subscription will help you to come back to this channel again and again, and that way you won't miss anything. So let us start. So finally, hello everyone. In today's video we are going to learn how to present a complete bedside clinical case in a third or fourth year MBBS practical examination. I am saying third year because all of your postings and all of your clinical classes start in third year. And this is not just going to be a case reading video. I'm going to also show you at the end of it that how to actually speak to the examiner and what findings are important, what they clinically mean, and finally how you should arrive at your provisional diagnosis and differentials. Our case is of a 73-year-old male with inflammatory joint symptoms, okay, and postural dizziness, oral lesions, and basal crepitations on chest auscultation. But you do not need to worry right now. I will be going in depth, and do not think that you are forgetting any text, because if I get like enough requests, I'll make sure that you guys get the PDF of it. So let us start. The first thing is, as we all know, is the identification. All right, these are the identification details. These are the real details, but I have not included the name, and I have to maintain the privacy of the patient that comes to us. So finally, also remember that this portion is always short, like it is not that long of a thing. Name, age, sex, then there is address, occupation, hospital name, and then there is the date of examination or date of admission. Okay, so this is how we start. Now in this case, suppose this is a patient, okay, then we will start as respected examiner or good morning, good afternoon examiner. I am presenting the case of Mr. XYZ, a 73-year-old male, address, resident of, for example, Lucknow, Uttar Pradesh, who is a retired manual labor and who is currently admitted in the male medical ward in our hospital, you do not need to tell the examiner the entire patient biography. Okay. You need to keep the examination as short as possible. Now, coming to the chief complaint, the patient presents with joint stiffness, joint pain, swelling, knees and hand joint. Always mention what joint. Okay, like this is important. In chief complaint we always think that we will elaborate in HOPI, but when you are saying that there is joint pain, stiffness, swelling, be specific for 1 month. Okay, now again I would like to emphasize that off mat likhna, since mat likhna, with वगैरह तो बिल्कुल भी मत लिखना. For is the keyword. Then there is generalized headache for 20 days and dizziness upon standing for 15 days, generalized weakness and oral lesion / ulcer for 3 days. Now, one thing is important, that in this you can see that the chief complaint is in chronological order. मतलब जो पहले हुआ वो पहले बताओगे. Now, history of, also remember the golden rule of chief complaint is you will explain the symptom plus duration. Never, do not miss any of it. Don't start by explaining the symptom here. The detailed description belongs to history of present illness. Now we are coming to the most important part, that is the HOPI. Joint symptoms. The patient was apparently asymptomatic 1 month prior to the presentation, following which he developed continuous, dull, aching joint pain. Okay. Joint pain, gradual in onset, involving bilateral knees. This is important. Prominently right knee and hand joints. ओके, मतलब यहाँ पे भी आपने ऑनसेट बताया और आपने कहाँ कहाँ कौन कौन सा जॉइंट इन्वॉल्व है, आपने वो तभी बता दिया. ओके. Morning stiffness, present for more than 30 to 60 minutes, worse in the morning or in the evening, interfering with the daily activities, relieved partially by medication. ओके, तो आपने ड्यूरेशन बताया, कब कब वर्स हो रहा है ये बताया, और इंटरफेयर कर रहा है डेली एक्टिविटीज़ से कि नहीं, और रिलीव कैसे हो रहा है ये भी बताया. Neurological and systemic symptoms. Generalized headache for 20 days associated with nausea, postural dizziness for 15 days resulting in a fall upon standing up. This is important कि जो हम लोगों ने डिजीनेस बताया था उसका रिजल्ट क्या हो रहा है. जो डिजीनेस आपने बताया उसका रिजल्ट घूम फिर के ये हो रहा है कि दैट पर्सन फेल, विच इज़ अ ह्यूज थिंग. Then there is generalized weakness with oral white patchy lesions / ulcers for 3 days. Now, negative history. Now also one thing is important कि जो ये joint pain है और ये morning stiffness है, Is this inflammatory or mechanical joint pain? Morning stiffness lasting more than 30 to 60 minutes strongly suggests an inflammatory pattern. Okay, so I'll write this. Wait a second. Okay, now coming back to this, and MCP involvement is important. That हैंड जॉइंट्स इसमें स्पेसिफिकली बोला गया है कि लेफ्ट थर्ड MCP जॉइंट मेटाकार्पोफैलेंजियल जॉइंट. ओके, नाउ दिस इज इम्पॉर्टेंट. why is this important? This is important because the small joints of the hands, especially the MCP and PIP joints, are classically involved in rheumatoid arthritis. This is why this is a really important point. Now coming back. So before reaching the examination, we have a clinical clue pointing towards inflammatory polyarthritis. Okay. These things are important. ये नैरो डाउन करवाता है कि पेशेंट को प्रॉब्लम क्या है. Okay, now coming back. Now there is one more important point, that there is dizziness upon standing up. मतलब posture involved है. Alright. मतलब it points towards postural or orthostatic hypotension. This is how you rule out things. Okay, now negative history. We will only consider the relevant negative history, and which is no history of fever or significant weight loss, no malar rash photosensitivity or alopecia. There is no history of cough hemoptysis, chronic diarrhea, or urethral discharge. Why are we asking these questions? These questions are important because the negative history is not random. Every negative history has a purpose. Now, what purpose do these things have? Malar rash, chronic diarrhea, respiratory symptoms. Okay, like what is the purpose? It has like very important purpose because it is ruling out things. All right. And how do we tell that what it is ruling out? Let us see what exactly it is ruling out. Okay. First thing, malar rash, photo, sensitivity, and alopecia it rules out SLE, which is what is it? 1, 2, 3. What is SLE? Yes, it is systemic lupus erythematosus. All right. Secondly, chronic diarrhea and urethral discharge. Rule out reactive or inflammatory arthropathies. Now, moving back to it, there is also one more thing that is very interesting. The respiratory symptoms become particularly important because rheumatoid arthritis can have pulmonary manifestations. Alright, but our patient may have lung involvement despite having no respiratory complaints. So that is very important. This point is not written, you can write it down. I'm speaking it. And that is something that we will discover on examination. Now, coming to the past history. There is no history of diabetes, hypertension, TB, or thyroid disease. Regarding the personal history, these are all different points, all right, that when you will write it down, you can write it down like 5, 6, 7. So do the numbering according to yourself. The patient consumes non-vegetarian diet and has a significant history of tobacco. He's a chronic tobacco smoker. There is inadequate sleep, obviously, and disturbed bowel habits. Regarding the drug history, he received brief outpatient treatment at a local hospital, which is a different location, alright, than Lucknow, 10 days prior to the presentation, although the medications are not documented. Now, this was the detail I gave earlier. Always ask about medications, alright. This becomes particularly relevant when the patient has new oral ulcers, weaknesses, or respiratory findings. The patient has, suppose if the patient has recently started, like suppose NSAID, alright, or steroid, or some other immunosuppressant thing, or like methotrexate. The differential diagnosis changes. But remember, in this case, the exact medications are not known, so there is like, we cannot say that the ulcers that he is having, they are drug induced. We cannot say that. On general examination, the patient is conscious, alert, cooperative, and well oriented to time, place, and person. Now, like, you can also comment on the position in which the patient is. Suppose if the patient is in the recumbent position, then you can say that if he is comfortable. How you can say that he is comfortable? He's sitting, talking. You can state that. Now, the vitals. Pulse. His pulse rate is 76 beats per minute, measured on the left radial artery. Normovolumic, regular, no radio-radial delay. This is something that you can learn. Mostly there will not be any other anomaly in your patient, but this is how you present pulse. These are the subpoints of pulse. Where it is measured, normovolumic, regular, no radio-radial delay. Then respiratory rate, 13 breaths per minute, regular, thoraco-abdominal. Thoraco-abdominal because the patient is male. Now the blood pressure. Now this is something that alright. We will say that the blood pressure is 130 by 80, alright, 130 by 80. And on palpation, if you can see, if not, the text is unclear, so only tell the auscultatory 130 by 80 mmHg. With postural drop, confirming the orthostatic hypotension. This is important because you will comment on this only if you have like measured it on standing up, like sitting, and then all of a sudden you measure it on standing up. Okay, and this needs to be documented, and this happens अगर अचानक से खड़े करके जब हम लेते हैं तो 20 mmHg का फॉल दिखाई देता है तब. This is clinical, alright. विच जैसे हमारे एग्जामिनेशन में भी यही पॉइंट कर रहा था ऑर्थोस्टैटिक हाइपोटेंशन की तरफ, और हमारा हिस्ट्री और एग्जामिनेशन को रिलेट कर रहा है. दैट इज़ ऑल आई एम सेइंग. नाउ द SpO2 इज़ नॉर्मल ऑन रूम एयर. Oxygen saturation, this is what it is. Now when you hear postural drop, do not simply memorize a number. Alright, like let me give you one more thing, one more note. Alright, sorry मेरा n नीचे चला गया, but let us focus. Alright, now it refers to significant fall in BP after standing comma classically a fall in systolic blood pressure of at least 20 Hg, or remember it's a or, diastolic BP of at least 10 mmHg. Alright, this was an important note. Now coming back to our examination, we'll continue general signs. On examination, mild pallor is present on the lower palpebral conjunctiva. Icterus, clubbing, cyanosis, lymphadenopathy, edema, they all are absent. Head to toe examination, the face is symmetrical. Hair and forehead grey in color, voluminous in hair, forehead creases are visible, eyebrows are grey, eyes opacity is present around the limbus. Alright, you have read this in your ophtha, arcus senilus. It means that the opacity is consistent with arcus senilus, which is again a pathology. In oral cavity, there are white patchy lesions, ulcer around the tongue, dental staining present consistent with chronic smoking. Nails, there are brittle nails. Now it is like important that the arcus senilus in a 73-year-old male is not itself diagnostic of a disease. All right, this is just what you see. And there is no need to force every finding, like this is not relevant to the case, but the patient has it, so do not force every finding to your disease. On local joint examination, there is localized swelling, tenderness over the lateral aspect of the knee. Alright, with local tenderness. In feet, no involvement is present. In hands, left third MCP is inflamed and tender. Elbow, no involvement, so you need to be specific. Like knee is involved and MCP is involved. You need to be specific about what joints you're talking about, like in this, legs, feet, hands, elbows. This is an important pattern, all right? So till now, we have inflammatory symptom, prolonged morning stiffness, and MCP involvement plus joint swelling. This makes inflammatory arthritis much more likely than simply osteoarthritis. Now coming to systemic examination, I will demonstrate it systematically. The upper respiratory tract examination, which you always forget. I forget it too, but it is important that we do remember it. On examination of nose and sinuses, both nares are patent. There is no deviated nasal septum. There is no paranasal sinus tenderness on examination of oral cavity and pharynx. White patchy lesions over the tongue and oral mucosa. Dental staining is present. Tonsils are non-enlarged. Uvula is midline. These are the things that you will need to see, alright? Like external contour, nares, sinus tenderness, tonsils, uvula, larynx and voice. Voice is clear. There is no hoarseness or stridor. Lower respiratory tract examination. Okay, and also like why this I said, every point is important, alright? Why did I specify this? Like just why? This is important because its involvement can produce hoarseness, throat discomfort, or even airway symptoms, alright? So this could become an ENT finding. Now coming back to our inspection. On inspection, the trachea appears centrally placed. The chest is symmetrical bilaterally and with normal elliptical contour. Equal respiratory excursion bilaterally. Spine and deformity, no gibbous or no prominence of spine/vertebrae is noted. Alright, this is important, and this is also important. Skin wall, no surgical scar, sinus tract or dilated veins. Now palpation. See how beautifully there are 7 points given. Alright, lymph node and sinuses, no enlarged or prominent supraclavicular, cervical or axillary lymph node, no sinus tract or discharging sinuses. Trachea centrally placed. Inspect at the sternal notch and confirm by feeling of bilateral cricosternal spaces using pulp of fingers. This is an important point. Chest wall, no localized tenderness, crepitus or palpable mass. Apex feet palpated in the left fifth intercostal space. Okay, medial to the midclavicular line, normal in character. Chest index, this is important because AP diameter and transverse diameter measure hota hai, which is 0.72, which is less than 0.75, which is within the normal limits. And this is important to note by because ये आपको पैल्पेशन में ही बोलना है, एंड ऐसा नहीं करना है कि ये आप इंस्पेक्शन में बोल दो और या फिर आप भूल जाओ इसे बोलना. नाउ चेस्ट एक्सपेंशन bilaterally equal across upper, middle and lower zones, anteriorly and posteriorly. Tactile vocal fremitus, equal and normal bilaterally overall, corresponding to all anatomical zones. Now these are the anatomical zones. Examiner asks this, and this is a very relevant question. Now in percussion. Now also, like, just because you know that you will get, finding in auscultation, do not jump to auscultation. Percussion. On percussion, normal resonant percussion note is elicited symmetrically across all lung fields. These are the lung fields that you will see anteriorly, laterally, posteriorly. Impaired note is absent. Cardiac and liver boundaries. Normal relative cardiac dullness boundaries. Upper border of liver. These are all very important. Noted at the fifth intercostal space along the mid-clavicular line. Special percussion test, tidal percussion and coin percussion. Examiner asks these, so you need to be very thorough about these. कि करते कैसे हैं, किया हो नहीं किया हो, does not matter. Tidal percussion, diaphragmatic excursion intact, which confirms what? It confirms intact phrenic nerve function and diaphragmatic mobility. Auscultation. Also in this, what are we looking for in this? We are looking for consolidation. There is any evidence of pleural effusion, pneumothorax, collapse, or any other altered percussion, but in this it is normal. All right, there is no anomaly, normal in all aspects. Now auscultation, the most important part of our lecture today, because इसमें हमें फाइंडिंग मिलेगी. On auscultation, vesicular breath sounds are heard bilaterally with equal air entry. Okay? यही तो बोलते हैं हम लोग हर बार. Now, however, on posterior basal auscultation, fine end inspiratory crackles with a Velcro like character are present bilaterally. Okay, तो इसमें सवाल बनता है, where did you feel this? On posterior basal auscultation. Velcro like character. All right. Now, the vocal resonance is normal and symmetrical bilaterally along all fields, and whispered pectoriloquy is absent bilaterally. I want you to remember that fine end inspiratory basal crackles, especially when described as Velcro crackles, should make you think of interstitial lung disease. All right. In a patient with clinical features suggestive of rheumatoid arthritis, this raises the possibility of rheumatoid arthritis associated interstitial lung disease. But remember, auscultation alone does not confirm RA-ILD. All right. So this indicates RA associated लंग डिसीज़. बट ऐसा नहीं है कि ऑस्कल्टेशन से आपको पता चल जाएगा पूरा. यू विल नीड अ CT टू कन्फर्म. ऑल राइट. देन पर्टिकुलरली HRCT. Then You will need pulmonary function test, diffuse capacity assessment, and overall clinical context. But the findings are suggestive of interstitial lung disease, possibly rheumatoid arthritis associated ILD. Alright. Now, abdomen is symmetrical, umbilicus is inverted and centrally placed. All four quadrants are moving symmetrically with respiration. These are all points. You should know all these points. Soft, tender, no organomegaly. Cardiovascular system, S1, S2 is heard, no murmur. Central nervous system, conscious, well oriented, no focal neurological deficit. Postural hypotension is noted. Provisional diagnosis. Now the provisional diagnosis is, I want you to remember and focus on only this part. Rheumatoid arthritis associated interstitial lung disease. Secondary findings is postural hypotension causing dizziness and mechanical fall, mucosal white patchy lesions or aphthous ulcers, ड्रग इंड्यूस टॉक्सिसिटी वर्सेस सिस्टमिक ऑटोइम्यून फ्लेयर भी हो सकता है, माइल्ड अनीमिया बिकॉज ऑफ द पैलर ऑफ क्रॉनिक डिसीज़, क्योंकि उसको इतने टाइम से एक ही प्रॉब्लम है, क्रॉनिक डिसीज़ है उसको, जिसकी वजह से माइल्ड अनीमिया है उसे. नाउ डिफरेंशियल डायग्नोसिस विद पॉइंट्स फॉर और अगेंस्ट. ऑलराइट, नाउ लेट अस स्टार्ट. Rheumatoid arthritis, this is our first thing. Point 4 में क्या क्या है इसमें? Inflammatory polyarthritis or involving small joints. Okay, left third MCP and large joints, knee. Prominent morning stiffness lasting more than 30 to 60 minutes. First of all, हमारा डिफरेंशियल डायग्नोसिस है किस किस का? रूमेटॉइड आर्थराइटिस का है, इडियोपैथिक पल्मोनरी फाइब्रोसिस का है, एसएलई का है, उसके अलावा ऑर्थोस्टैटिक हाइपोटेंशन और ड्रग इंड्यूस्ड. ऑलराइट, नाउ कमिंग बैक टू दिस. ऑफ स्मॉल जॉइंट, लार्ज जॉइंट, मॉर्निंग स्टिफनेस जो कि लास्ट करिए मोर देन 30 to 60 मिनट्स, bilateral basal fine end inspiratory velcro crackles on chest auscultation and high risk demographic profile, क्योंकि उसको हिस्ट्री है क्रॉनिक टोबैको स्मोकिंग का. ओके, स्मोकिंग से होता क्या है कि प्रोटीन सिट्रुलिनेशन हो जाता है, जिसकी वजह से RA और RA ILD दोनों हो सकता है. पॉइंट अगेंस्ट, प्रीडोमिनेंटली एसिमेट्रिक प्रेजेंटेशन एट द करेंट टाइम, मतलब राइट नी है, लेटरल स्वेलिंग लेफ्ट थर्ड MCP जॉइन थ्रू RA. RA में मोस्टली सिमेट्रिकल होता है, एब्सेंस ऑफ क्लासिकल हैंड डिफॉर्मिटीज़. जैसे कि इसमें क्या होता है, इसमें क्लासिकल डिफॉर्मिटीज़ मिलती है ना, स्वॉन नेक मिलता है, बोटेनियर्स मिलता है, अल्नर डेविएशन मिलता है. ओके, moving on, idiopathic pulmonary fibrosis with coexisting osteoarthritis. फॉर्म में क्या क्या है? एल्डरली मेल है, क्रॉनिक स्मोकर है, वेलक्रो अगेन, नी जॉइंट स्वेलिंग. ओके, क्योंकि ये कॉमन साइट होती है फॉर प्राइमरी OA, ऑस्टियोआर्थराइटिस. नाउ पॉइंट अगेंस्ट, इन्फ्लेमेटरी जॉइंट फीचर्स जैसे कि मॉर्निंग स्टिफनेस है, उसको एक्टिव इन्फ्लेमेशन है. ओके, MCP जॉइंट्स आर टिपिकली स्पेयर्ड इन ऑस्टियोआर्थराइटिस, तो इससे ऐसा लग रहा है कि नहीं है. प्रेजेंस ऑफ अक्यूट म्यूकोसल अल्सर्स है, सिस्टमिक वीकनेस है विच इज़ नॉट इंडिकेटिव ऑफ OA. ओके, एंड देन सिस्टमिक ल्यूपस एरिथेमेटोसिस विद ल्यूपस न्यूमोनाइटिस और ILD. फॉर्म में क्या क्या है? पॉलीआर्थराइटिस है, स्मॉल एंड लार्ज जॉइंट्स का, ओरल म्यूकोसा अल्सर्स एंड अनीमिया. ओके, अगेंस्ट क्या क्या है? मेल पेशेंट है, नॉर्मली SLE फीमेल्स में होता है. ओके, एंड देन देर इज़ नेगेटिव हिस्ट्री ऑफ मलार रैश, फोटो सेंसिटिविटी, एलोपेशिया, डिस्कॉइड लीजन्स एंड रीनल इन्वॉल्वमेंट. ये सब हमने हिस्ट्री से रूल आउट किया था. सेकेंडरी और कॉम्प्लिकेटिंग कंडीशंस में ऑर्थोस्टैटिक हाइपोटेंशन तो उसको है, ओके, बट सेकेंडरी टू सम ऑटोनॉमिक डिसफंक्शन और डिहाइड्रेशन और ड्रग्स। फॉर में क्या क्या है? देयर इज़ क्लियर हिस्ट्री ऑफ डिजीनेस अपॉन ट्रांजिशनिंग फ्रॉम सिटिंग टू स्टैंडिंग, ओके, कल्मिनेटिंग इन अ फॉल, रिकॉर्डेड पोस्चरल ड्रॉप इन बीपी। ये सब कुछ हिस्ट्री का पॉइंट है जो हमने हिस्ट्री में बताया है। अगेंस्ट में क्या क्या है? इट डज नॉट एक्सप्लेन द प्राइमरी इन्फ्लेमेशन, जॉइंट पैथोलॉजी तो इसमें बताई ही नहीं ना। नाउ ड्रग इंड्यूस्ड म्यूकोसाइटिस और हाइपर सेंसिटिविटी न्यूमोनाइटिस, मीथोट्रेक्सेट ड्रग इंड्यूस्ड। फॉर में क्या क्या है? रीसेंट आउट पेशेंट एडमिशन एंड ट्रीटमेंट एट द लोकल हॉस्पिटल, उन्होंने क्या दिया ये भी बहुत इंपॉर्टेंट है। एंड रैपिड 3-day ऑनसेट ऑफ ओरल पैची लीजन्स और अल्सर्स। अगेंस्ट में वेलक्रो, क्योंकि इसका अगेन हमारे पास कोई एक्सप्लेनेशन ही नहीं है ड्रग इंड्यूस से। सो दिस इज़ वाई एंड दिस इज़ हाउ वी मेक आवर डायग्नोसिस। नाउ you can take the photographs of this. This is how you will present it to the examiner. And I have, if you want this PDF, I'll send you the PDF, but either you can subscribe to the channel or you can follow me on Instagram. My Instagram handle is AUTHORGAURI, author Gauri, and I'll send you the PDF. So, or you can take the screenshot, it is up to you. I have completed each and every point. And also, how do you present the summary? In summary, respected examiner, my patient Mr. XYZ, a 73-year-old male and chronic tobacco smoker, is a case of, you will say, RAILD, okay? There is no, like, you can't say this now possibly. That is why. With inflammatory polyarthritis involving right knee joint, left third MCP with morning stiffness accompanied by orthostatic hypotension causing postural dizziness and a fall and oral mucosal lesions. Systemic examination confirms rheumatoid arthritis associated interstitial lung disease, evidenced by bilateral basal fine and inspiratory Velcro crackles. All right. On chest auscultation with no current signs of consolidation, pleural effusion, or acute airway obstruction. Then you will say, I have completed all these points. This is just for your screenshot purposes. Do not forget to subscribe to my channel, and yeah, do not forget. This is my like third, fourth, or fifth video maybe, but this is my second medicine case. And before this I have covered asthma. So stay tuned and thanks for watching.